तर आजचा आपला आता कार्यक्रम चालू करूया. आपला फेब्रुवारी महिन्याचा जो कार्यक्रम आहे त्याच्यासाठी सर्वांचं स्वागत. आपल्या सगळ्यांना माहितीच आहे की 2 आठवड्यापूर्वी आपल्या सर्वांच्या माहितीच्या लता मंगेशकर त्यांचं निधन झालं. आपण सर्वांनी 1950 सालापासून लता मंगेशकरची गाणी सगळी ऐकलेली आहेत, तोंडपाठ आहेत. मला वाटतं तिचं पहिलं जे गाणं पॉप्युलर झालं ते गंगा यमुना जोड्यात उभ्या का, ते मोठं विविध भारती आणि रेडिओ सिलॉनवर रोज ते प्रसारित व्हायचं. तर त्यांना श्रद्धांजली देण्यासाठी प्रथम मी दुर्गा बादशाहपूरकर विनंती करतो.
नमस्कार. आज माझ्यावर लता मंगेशकरांना श्रद्धांजली वाहण्याची जबाबदारी उलगुंदाने टाकली आहे. वास्तविक आपण कोणीच त्यांना कधी आहोजाव केलं नाही. याचं कारण कायम लता असाच एकेरी उल्लेख करत आलो, कारण आपण देवाला तरी कधी आहोजाव करतो. देव कितीही महान असला तरी तो जवळचा वाटतो. ते आहो केव्हाच गळून पडतं. आपल्या भावविश्वात तेच स्थान लताचं आहे. 2 आठवड्यांपूर्वी रात्री उशिरा BBC वर्ल्ड न्यूज लावलं आणि सलामीची बातमी लताच्या निधनाची होती. आणि मग दुसऱ्या क्रमांकावर राणी एलिझाबेथच्या राज्यारोहणाला 70 वर्ष झाली ती बातमी. मला तशातही सुखद धक्का बसला, पण आश्चर्य नाही वाटलं, कारण भारतरत्न लताचं स्थान जगात किती उंचीवर आहे याची ती जणू प्रचिती होती. 1960 साली मी इथे येण्याकरता भारत सोडला तेव्हा वैयक्तिक सामानाशिवाय 2-3 मराठी पुस्तकं मावली होती. पण काहीतरी महत्वाचं राहून गेलंय अशी हुरहुर सारखी वाटत होती. इथे आल्यावर नवऱ्याच्या संन्याशाच्या मठीत एक टेप रेकॉर्डर आणि 7-8 रील टू रील टेप सापडल्या. पहिली टेप लावली आणि लताचा सुमधुर आवाज कानावर पडला आणि मग ती हुरहुर कशाची होती हे लगेच लक्षात आलं. आणि त्यानंतर आजवर सतत लताच्या आवाजाची सोबत असतेच, कारण लहानपणापासून लताचा स्वर्गीय आवाज हा आपल्या जीवनाचा एक अविभाज्य आणि गृहीत धरलेला घटक होता. गेले 2 आठवडे लतावर आधारित अगणित चित्रफिती आणि मजकूर यांनी इंटरनेट भरून ओसंडत आहे. म्हणजे एक नक्की की लताचा नश्वर देह जरी हे जग सोडून गेला असला तरी तिच्या संगीतातून ती सतत या जगात असणार आहे. मरावे परी कीर्तिरूपी उरावे म्हणतात ते हेच. ह्या 5 मंगेशकर भावंडांच्या दारात संगीताचा कल्पवृक्ष लावून दीनानाथ मंगेशकर हे जग सोडून गेले ते साल होतं 1942. थोरली लेक या नात्यानं वयाच्या अवघ्या 13व्या वर्षी लतानं साऱ्या संसाराची जबाबदारी उचलली. तिची ती सुरुवातीची धडपड वणवण फार काळ टिकली नाही, कारण तिची संगीत साधना तिला फार उंचावर घेऊन गेली. सुरुवातीला युसुफ भाई उर्फ दिलीप कुमारनी थोडं नाक मुरडलं आणि तो म्हणाला होता की ह्या कृशमुरीच्या गळ्यातून उमटणाऱ्या स्वरांना वरण भाताचा असा मराठी वास असेल, कारण ती मराठी आहे. लतानं जिद्दीनं ते म्हणणं खोटं पाडलं. उर्दू शिकून घेऊन लवकरच तिनं ज्या आत्मविश्वासाने आपलं स्थान पक्क केलं ते पुढची 60 वर्ष. लताच्या खात्यावर 36 विविध भाषांमधून 35,000च्या वर गाणी रेकॉर्ड केलेली आहेत. हा विक्रम गिनस वर्ल्ड रेकॉर्ड बुक मध्ये नोंदवला गेला आहे. महाराष्ट्रानं टिळक, कर्वे, गोखले असे अनेक महान नेते भारताला दिले. गावस्कर, तेंडुलकर सारखे जागतिक कीर्तीचे क्रिकेटपटू दिले आणि एक लता मंगेशकर दिली. कुमार गंधर्वांसारखे दिग्गज म्हणाले होते की गळ्यात गांधार घेऊन जन्माला आलेल्या लतानं भारतीय शास्त्रीय संगीत हे जे होतं ते भारताच्याच नाही तर जगाच्या कानाकोपऱ्यात पोहोचवलंय, अगदी महालांपासून ते झोपडीपर्यंत. भीमसेन जोशी तर एकदा म्हणाले होते, त्यांचं राम श्याम गुणगान हे लता बरोबरची रेकॉर्ड झाल्यावर, की ह्या शास्त्रीय संगीतात शिरल्याने ते माझं भाग्य, नाहीतर तिथेही त्याच वरचढ राहिल्या असत्या. आता एका भारतरत्न थोर कलाकारानं दुसऱ्या भारतरत्नाला अशी दाद दिलेली ऐकली की ते महत्व नुसतं पटत नाही तर ते अधोरेखित होतं. आज लताला आदरांजली वाहताना मन नक्कीच हेलावलं आहे, पण तिचं नक्षत्रांचं देणं इतकं मोठं आहे की आपण सगळेच त्या ऋणात सदैव राहू.
मुख्य कार्यक्रमाकडे आपण वळूया. काही 2 वर्षापूर्वी आपण एक हेल्थ सिरीज चालू केली. त्या सिरीज मध्ये आरोग्य विषयक अनेक प्रकारची प्रेझेंटेशन झाली आणि याच्या पुढे पण ती चालू राहतील. तर याच्या पुढे आता एक नवीन सिरीज चालू करतोय, नो द वर्ल्ड अराउंड यू. की गेल्या 2 दिवसामध्ये मी स्टार आणि ग्लोबल मेल मध्ये एक जाहिरात वाचली. त्या जाहिरातीमध्ये लिहिलं होतं, सिनियर्स नो ए लॉट बट देर इज ऑलवेज समथिंग एल्स टू लर्न. म्हणजे आपल्याला कितीही माहिती असली, कितीही गोष्टीमध्ये ज्ञान असेल, तर अशा अनेक गोष्टी असतात की ज्याची आपल्याला माहिती असत नाही. आणि ती माहिती करून घेणं म्हणजे आपल्याला आपला जो अनुभव आहे तो जास्तीत जास्त चांगला करणं असं होतं. खरं पाहिलं तर आपल्याला ज्या गोष्टी माहिती आहेत त्याच्यापेक्षा कितीतरी जास्ती गोष्टी आपल्याला माहीत नाही आहेत. तर त्यातल्याच काही गोष्टी प्रत्येक कार्यक्रमाच्या वेळेला निवडून त्याची माहिती लोकांच्या बरोबर पोचवावी असा हेतू आहे. अनेक विषय आहेत, साधे ज्या गोष्टी आपण रोज पाहतो पण त्याच्याविषयी आपल्याला कुतूहल असतं, पण आपण त्याच्यामध्ये जास्ती माहिती काढायचा प्रयत्न करत नाही. तर अशा गोष्टी लोकांच्या बरोबर पोचवायचा विचार आहे. तर त्यातली पहिली जी हे आहे, पहिलं जे प्रेझेंटेशन आहे, तर त्याच्यासाठी सुदीत रानडे हा आपल्याला प्रेझेंटेशन देणार आहे. सुदीत इथंच लहानपणापासून वाढलेला आहे, आपण अनेक जण त्याला ओळखत असू. तर त्याची योग्य प्रकारे ओळख करून देण्यासाठी मी अर्चना बापटना विनंती करतो. अर्चना.
सर्वांना एकत्र बघून खूप छान वाटतंय. आज मुळगुंदांनी माझ्यावर सुदीतची ओळख करून देण्याची जबाबदारी टाकली आहे. ती ओळख मात्र मी इंग्रजीमधून करून देणार आहे, कारण सुदीतची बायको ब्रिटा हिला मी काय म्हणते ते कळेल. It's my pleasure to introduce Dr. Sudit Ranade. If I say I know him since his birth, it won't be an exaggeration. मी त्याच्या बारशाच्या घुगऱ्या खाल्ल्या आहेत. From childhood, he is focused, hardworking, and competitive by nature. He completed medical school at the University of Ottawa, trained in family medicine, public health, and preventive medicine at Queen's University, MBA in public health, worked with WHO as an intern, has been medical officer of health for Lambton County since 2012. Beside his profession, he is interested in music, traveling, even in cooking, like his father, Mr. Prabhakar Ranade. On personal note, I like his involvement in politics. He is an asset to our medical profession, our voice to improve our medical health and health. All the best, Sudit, for your dedication towards our health. Thank you.
Thanks, Archana. Sudit, now the floor is yours.
Thanks, Mukund Kaka. Hi, everyone. Thanks, Archana Maushi, for that introduction. It's funny that you mentioned my hobbies. What I actually wrote was that I used to have hobbies, but now I have children, so there's no time for hobbies.
Okay. That is for the future. You know, the children are going to grow soon.
That's true. So it's so nice to see all of you. It's really just, I miss all of you so much. And I wish that we were in a time where we could do more gathering. And I know that it's been a long time where people haven't been able to do it, but I think, I hope that we're getting to a place where we can have those more kinds of get-togethers again soon, because I think everybody's doing everything that they can with Zoom, and it's nice to kind of keep in touch this way, but sometimes it's not the same as just actually getting to see someone in front of you, right? So I hope that we can do that soon. And thank you to all of you, and thanks to Morgan Kaka for inviting me to do this. I think it's an interesting fit to talk about the world around you, and then to ask me to come and talk about public health, because it feels like before the pandemic, nobody really knew what public health was or what public health was doing. And now all of a sudden, public health and public health people and public health operations are everywhere in the news, right? So it's become all of a sudden a thing that we used to be kind of in the background doing things, and then now we're in the forefront because of the pandemic, and maybe some of us are looking forward to taking a step back again when as the pandemic recedes, right? So I'm going to share my screen with you, and I'm going to just kind of start. Essentially, what I'm going to try to cover today is just sort of, a little bit about the what public health does in general, what we've been doing during the pandemic, a little bit about sort of what I do as the medical officer of health and how that connects it to what everybody else has been doing in the pandemic, and then we'll have some time for people to ask questions and whatnot. Talk a little bit about this particular pandemic as well, and what we've experienced through it, and what has. Where we think it might go also, in case that's helpful to anybody. I was thinking about what Durga Maushi said about Lata Mangeshkar, and that, Raya Kaka used to tell this story about how she would go in for some recording sessions and just like not even one take, and it was done. Just, okay, that was it. That was the perfect version. No changes need to be made. And so I kept thinking about that after all of the news articles about her. And I thought that's such a amazing talent to just go in there and be like, okay, I got this. It's done. First time. So what I was going to talk about today is called pandemics and public health, right? It's the connection between what we've been doing and what we've been seeing around us. So we're going to talk a little bit about, in order to understand that, we have to go right back to the roots. We have to start thinking about what is health itself, and then what is public health, and then how is the public health system structured, who are medical officers of health, and then talk about what has the pandemic meant in terms of public health work, and what have we been doing, and what have been some of the issues around that, right? We have to really talk about what health is, and the World Health Organization a long time ago in the late 40s talked about health as a state of complete physical, mental, and social well-being, and not the absence of disease, right? So that's really important, because when you make health something more positive, then it actually encompasses more things. So it means that there's more things that you have to actually do in order to achieve health than just be free of disease, right? No definition is perfect, because what is complete physical and mental health? What is well-being? And is it like a subjective thing that belongs to each person, or is it an objective thing that you can measure? And it's actually probably both, right? There's other definitions that people have talked about, like health as the ability to adapt, health as a resource, health as a baseline for achieving things that you want to do in your life. But the most important thing that we think about when we think about health is that it really depends on the context that you're talking about. So is there a way to talk about, for example, a healthy diabetic, right? And probably there is. When you go to medical school, diabetes is a disease. This is how it works. This is what it does. And this is how you treat it. But we don't really talk that much until later years about, well, what does it mean to be healthy and to have diabetes, right? So a part of it is to prevent people from getting diabetes in the first place, just as an example. But the other part is that there's also a way to live healthily and to be healthy, even in the face of having certain diseases, right? And so that's part of the thing that we try to achieve, not just in public health, but in some kinds of healthcare, where we're saying, look, you don't have to, it doesn't mean that you're unhealthy because you have these particular things, but there's a way to figure out what health means to you and then incorporate the management of that disease into what it means to you to be healthy, right? So if we can go to the next slide. Thank you. There are four primary ways that we can think about health, right? We can think about it as being just belonging to you, whether or not you're healthy as an individual, and what that means to you. How healthy do you feel? What do you need in order to feel healthy? And how do you put health into the context of your life, right? But there's also individual objective things. So what do the objective measures say about your individual health? And what are the things that are needed in order to change those objective measures in order for you to be healthier according to those measures, right? So those are two ways to think about it at the individual level. And then when you think about it as a group of us, as a community, as all the people who are on this call, as a population, there's a collective subjective way of thinking of health, right? So how healthy does our community feel? What do we think that we need as a community in order to achieve health or to be healthier? And then what do the objective measures say about our population and about our community, right? In terms of what indicators of health that we have, and how do they compare to those of other populations, right? So we're going to talk a little bit about that. So maybe if we can go to the next slide. Thank you. And the one after that. Okay, so the first part really is, what does being healthy mean to you? And it's totally different, right? If I ask each of you individually, what is it that you think health is, or what does it mean for you to be healthy? Probably we would get as many different answers as are on this call, right? But it's important to remember that only a part of what you think it means to you to be healthy is within your control. And then there's this other part out there that kind of belongs to the external environment, right? How does it impact you? What is your interaction with it? And how does that impact whether or not you're healthy? So if we can go to the next slide, please. And it turns out that if you ask different groups of people, they will actually say different things about what it means to be healthy. So there was a study of 20 Hispanic workers at a potato processing plant that a group of researchers did in 2017. They said, 2017, what does being healthy mean to you? What does being healthy mean to you? And the core answer that they got after kind of sifting through all of these people and all their answers and whatever, was that really for this group of people, being healthy means the ability to work and having physical mobility, the ability to move and walk and talk, right? That was sort of what their expectations of what it meant to be healthy were. You have to think about it in context, because in the context in which they're being interviewed at work. Work is a critical part of their lives. And if they're not able to work, then that impacts every other thing that they can do in their life or not, right? So they focused what they thought as being healthy as the ability to work and physical mobility. But if you ask 34 teenagers in Italy, what does being healthy mean to you? There was much more varied dimensions to it for them, right? They focused on physical appearance and how they look. They focused on their personal commitments and goals. They focused on the things that they have and the space that they have around them, how they can use their free time, and the fact that they belong to different social groups, right? When you ask 18 young mothers, really young mothers, like young teenager mothers, I can't remember where that study was done, but their core, concept of what being healthy was the ability to take care of their body, not being stressed out, and having the things that they need. So just from 3 studies, you can see that what it means to be healthy varies tremendously between different groups of people. And so that has implications for what when we go to the next level of saying, well, is our community healthy? Is our population healthy? You have to address the fact that everybody actually has different meanings attached to what health is. And is there a way to even achieve any of those meanings for a group of people, right? Next slide, please. So there are ways now when you talk about individuals that you can measure their health. You can see about different measures that kind of correlate or connect to their health. And it may or may not be connected to what they actually think of as being healthy, right? So if we go to the next slide, we can talk about things like blood pressure. We can talk about things like blood sugar. We can talk about things like measuring your height or your waist circumference or your head circumference for young kids. Or we can do blood indicators, measurements of your A1C or your cholesterol or various other things, right? And then we put them together along with the assessment of the individual to say, here's what you told me about what it means to be healthy for you. And here's what I see in terms of what we consider whether or not you're healthy according to sort of, either not having some diseases or being at risk for other diseases and so forth, right? So the next slide, please. So it's important to take all of those objective measurements into context, because when you ask yourself a question of what does high blood pressure mean? We have lots of people with high blood pressure. What does it mean? Sometimes it's a signal of a problem, right? If you have repeated measurements of high blood pressure over time and they're persistent, then that can be a risk factor for heart disease. It's also associated with other metabolic diseases like having high cholesterol, having diabetes, and so forth, right? A high blood pressure could actually be a reassurance of, a normal blood pressure could be a reassurance of that everything's okay if you're asking questions about other symptoms, right? It can inform other kinds of diagnosis, but a high blood pressure could also mean absolutely nothing, right? If you take it out of its context, or even depending on the context, it may not mean anything is wrong. When you're exercising, it's very normal to have a higher blood pressure. If you're under stress, it's very normal to have a high blood pressure for the period of time that you're under stress. And so every objective measurement that you take about a person needs to be understood in the context that it was taken and in what it might mean for what you're actually trying to look at, right? So we always say you never treat the number, you always treat the patient. And in some patients, that number will mean something different, and the same number in a different patient in a different context could actually mean something totally different, right? So you look not just at the number, but also at the patient. Next slide, please. So the problem with this idea that there are some objective measures of individual health, right, is that the thresholds for those measures are generally arbitrary, right? So if I took your blood pressure and I said, oh, it's 142/85, technically, that is high blood pressure, right? It's not that high, but it is a little bit higher than the thresholds that are set for what we call high blood pressure. And the problem is the thresholds are sometimes they're based on evidence, sometimes they're based on a group of people who work in that field getting together and saying, this is what we think the threshold should be. And that threshold can change over time. So in fact, some of the indicators or measurements that we might take now that we would have called, medium risk 10 years ago, because the guidance has changed, groups of people got together and said something different about what the measures should mean, those measures might actually be called high risk now or low risk now, right? So you have to remember that these thresholds are arbitrary. They're mostly kind of guesses, our best guess about what your actual risk is, right? And they're given different priorities between the physician and the patient. Right. And so I have lots and lots of examples of this, but maybe one of my favorites is, I remember talking to my Maushi in India, and she had significant diabetes. And she said, well, the doctor told me not to take any sugar in my tea. And so she would take sugar in her hand and eat it and then take a sip of tea after it. And I was like, you're basically doing the same thing. But you can see how the objective idea of, well, this is what's going on with you translates differently into a person's life, right? So it's really, really important to make sure when we work with patients that we're also thinking about how is the information that we share with you going to be used in your life? Are you going to make use of it? Are you going to do, things with it that are actually going to make a difference for your health? Next slide, please. Can we go to the next?
Why is it not doing?
Okay, thank you. So what we do, right, so this is probably something that's fairly familiar to you in terms of what physicians do, right? We work with patients to try to understand what their needs and expectations are. We apply a diagnostic lens. So we try to say, here's my assessment, here's what I see, here's what you've told me, here's some of the lab results and other values and testing that we've done, and pull it all together into some kind of diagnosis, which is both using the objective measures and then the things that, the subjective objective values and things that you've told us as a patient. And then the job is work together to recommend treatments and work with you to say, okay, how can we help you to be healthier based on both what you think health is and what we see here in front of us, right? So does that always happen every single time you go to the doctor? Probably not, depending on what it is for, right? But in principle, that's what everybody is trying to do, is to work with you to figure out what you need and expect, assess and give you a diagnosis, and then work with you and other players in the healthcare system to get you the things you need to be healthier. Okay, next slide, please. But so now that brings us into sort of what is public health and how is that different from the what we think of as the healthcare system, right? Because there's a healthcare system over here and there's a public health system over here. And sometimes they overlap. Sometimes we see some of the same patients, but in large part here, we're working with programs and communities and populations. And over here on the healthcare side, we're working with individuals. So let's go to the next slide. Public health is really defined as the science and the art of preventing disease, prolonging life, and promoting health through the organized efforts of society. So that's a big definition. It also means that lots and lots and lots of things that people do constitute something that works towards public health. So one of the examples I always give is community groups actually serve a public health function because they keep people socially connected and they may act as referral points for people who identify a need to get access to different services that can then help those people individually, right? So that's a organized effort of society, a group of community members who all belong to that community, working together to promote their health. So it's not a public health agency running a program, but it is actually public health work, right? Because it is advancing the health of the members of that community. Next slide, please. So these are the things in public health that we think of as determining your health. And it's a little bit different from how we think about when I see you as a patient and maybe you have this, an elbow pain and we're going to evaluate that. But it's a bit of a broader context at looking at the kinds of things that make people healthy, right? So there's your body. Let's start with that. There's your body and what you do with it. But that is determined by where you are and who you're with and what role you have and what skills you have. Those things are determined by where, the larger context of the system that you live in. What are the resources that are available there? How are they distributed? And that's determined by things like our culture, by things like our society, by things like the historical, legacies that we bring forward into the present from the past, right? And the things that we're doing today that will shape the future. So there's a bit of a philosophy that goes on there in terms of what public health is and how all of the things that happen in society, even the things that are happening, somewhere else that you think may not be connected to you directly, can actually have a very direct impact on your health. Then the pandemic is probably the cleanest and most relevant and current example of that, right? That there was a time when we thought, oh, that thing is just happening over there, right? And now you really can't say that about coronavirus at all. There is no over there with coronavirus. It's just everywhere and it's going to persist. We could talk about that in a minute. But there's so the real piece about public health is highlighting the connections between things that happen over there that may or may not be relevant to your health and how they impact your health or the health of the community or the health of the population. So next slide, please. And even public health has gone through an evolution as well, right? We started off in the 1800s being all about hygiene and sanitation. So it was make sure everyone has clean water, make sure we treat our sewage so that doesn't go around infecting people, use basic hygiene measures, and that was how it started. And there are lots of places in the world and even places in Canada that still need those basic sanitation measures, right? When we look at Walkerton, when we look at other things, we see how important having clean water is in our population, right? And how that's an ongoing effort to make sure that our water supply is both clean and safe to drink, right? And not contaminated with other contaminants. So that was where it started. Public health started as being, how do we get rid of cholera? How do we get rid of, how do we address basic sanitation issues? And then when we started learning more about infectious diseases, we moved into the world of antibiotics and vaccines. So the ability to treat infections and the ability to prevent them with vaccines, right? But over time, we've also moved into these other spaces and thinking about how does the environment affect our health, right? If you look at the air pollution in Delhi, for example, and in other large cities around the world, there is excellent quality evidence that that air pollution shortens lives, right? It impacts our lives at a population level by reducing life expectancy and increasing cardiovascular mortality. So air pollution is one of those things we go, oh, it's terrible. But it's also actually really has very significant impacts on population health, right? And so there's an argument that as a health, for health reasons, these different environmental stressors need to be regulated and managed. Water pollution is also a big one, and occupational health. We've learned a lot about how the design and the context of your work affects your ability to be healthy, right? Then public health moved on into social determinants. We know that income and education and race and social inclusion and housing are critical determinants of health in ways that we're learning more and more about every day. But the evidence is also very solid there, right? That actually your health trajectory is critically determined by how much income you have, what your education level is, what neighborhood you grew up in, and the context of that neighborhood. And as we learn more about that, it becomes more of a focus of what can we do to intervene there to maximize the potential health that people have over their lives. And then we move into this idea of cultural determinants, right? Health is so culturally determined in terms of, intergenerational effects that are not only cultural, but transmitted actually through our DNA, which is a really interesting finding that people have found over time. Social values, solidarity. So when you look at the way that the pandemic has been managed, probably the response in any country, no matter what it was the effectiveness of that response was determined by the broad level of solidarity in the population. The idea that we all need to work together to do something, the idea that we're all part of a greater whole, right? And so societies that have greater solidarity have had better responses to COVID throughout the pandemic than societies that are generally more fractured. Next slide, please. So because public health is the organized efforts of society, it becomes, it's the science piece of it is us asking ourselves, how should we intervene? In what ways? For what reasons? What is going to be the impact of that intervention? What are going to be the impacts that we didn't mean to happen, the unintended consequences, right? How big is going to be the difference that we make in population health? And how big is going to be the difference that we make at the individual level? How do we prioritize among the different interventions in order to maximize our impact? And how can we best work with different partners and stakeholders in the community to understand and address these different issues? So a good example of that is really the opioid crisis, right? There have been times through this pandemic where far more people died from opioid overdoses than from COVID. And so at the population level, there's a significant burden from the use of opioids. But that problem is not something that public health can tackle alone, right? That is a problem that everybody actually needs to pull together to kind of come to community level solutions for issues that are, that might be a little bit different community by community. And so we're starting that path in public health of working with these different communities to understand how does the opioid overdose issue play out in different communities and what can be done about it in each one, right? Next slide. And the one after, please. So now we're going to talk more about collectives, all of our health, the health of us together, right? As opposed to the health of just one person. Maybe if we go to the next one. So here are some objective ways that we can talk about population health, right? So otherwise, if you can't measure it, how are you going to know what's high, what's low, what's good, what's bad, all of that, right? So some of the ways that we measure population health are basic demographics. What's the age and sex structure of a population? What's the population level life expectancy and how does that change in different age groups and sex groups? What's the infant mortality rate, right? What's the quality of life and living standards and how are those distributed across the society? So that's one piece we can look at. We can look at measures of disease burden, like what percentage of people have different chronic diseases? What percentage of people have different infectious or communicable diseases? What are the outcomes of those diseases when they've been identified? So a good example of that is HIV. So 15, 20 years ago, a diagnosis of HIV was totally different than a diagnosis of HIV now. When we make a diagnosis of HIV now, we can actually say to people, we treat this like a chronic disease. We can put you on medications that are going to keep this under control for a very long period of time. So what you can start to do is look across different societies and say, now that we know that we have this and that the treatment path and the prognosis of HIV is very different, what does that prognosis look like in different countries? Which is a proxy for saying, how do different countries, give resources to treating and controlling HIV, right? So looking at the disease outcomes can help you understand what the population health is. And then you look at measures of capacity. What's the health system capacity? What's the vaccine coverage rates? What's, those kinds of things to understand how well resourced the system is and what impact it's having. Next slide, please. But there's also this subjective piece to population health, right? So if we go to the next one. We have to find a way of understanding subjectively, what does a population think, right? So if I ask all of you, is the Marathi community in Toronto healthy? Well, what does that mean, right? We'd have to understand, what does health mean to you? Are you doing the things that you want to with your lives? Are you able to access, the things that you need in order to stay healthy according to you? So in order to understand that, we do community surveys, we do focus groups, interviews, polls, community consultations, right? To get that picture from people. We talk to community leaders, we talk to elected people, we talk to institutional heads, key influencers and social networkers and things like that to understand what people are saying and thinking about it. And then there's also a research side where you can kind of do some really detailed research into the lived experience of communities and cultures, right? There's a lot of that in our area in terms of doing some lived experience research into different First Nations populations and how their interactions with the environment have changed over time to impact their health, right? Next slide, please. So the basic distinction here is that public health is really the health of the whole. It's about intervening at the level of all of society. It is the whole forest, the health of the whole forest. We have a major focus on preventing disease and then a minor focus on treatment and mitigation of disease, right? And then healthcare, the way we normally think of as I went to the doctor and this is what happened, is really about health of the one. And you try to look at the whole picture of one person, right? But at the core, it's about that individual, about individual interventions targeted at specific patients with a major focus on disease treatment and maybe a lesser focus sometimes on prevention. So public health is the health of the whole forest. Healthcare is about which of these trees is sick and what do I do about it? Okay, let's go to the next slide. So we know that health starts very early. There was a really good report in Ontario that talked about how if all Ontarians did the things that we know we're supposed to do, right? That we were more physically active, we all stopped smoking, we cut back on drinking, we had a healthier diet of more vegetables and lower saturated fats, and we had lower stress in our lives, that on average, our population would have an extra 7 to 10 healthy years of life. Not just 7 to 10 years where you're progressively declining, but an extra 7 to 10 healthy years of life, which means you can do the things that you want to do with your life for an extra 7 to 10 years. Now, there's a bit of a challenge here, right? Because it doesn't mean that every individual is going to have that benefit. But if all of us do these things, then at the population level, on average, our life expectancy would go up by 7 to 10 years, which is huge. That is a dramatic increase in life expectancy, right? But getting there is a big challenge. You have to start making physical activity easier to do and more culturally, indicated, and all of these other things. There's all these, and so that's the science of public health intervention. How do we intervene at the population level to help people be more physically active, to help stop them smoking, to help them cut back on drinking, to give them a healthier diet, and to lower their stress levels, to give everyone 7 to 10 extra healthy years? Next slide, please. So another key point is that 80% of what we think of as being as health, as the things that are responsible for your health, are outside of the control of the healthcare system. And 20% of what we consider to be health is controlled by the healthcare system, which is, do you have access to care? Do you have the diagnostic services and the treatment services and whatever? That's really 20% of what it means for you to be healthy. And the other 80% is all outside of healthcare. It's what you do in your life and where you are and what the systems and structures are around you. Next slide, please. And so if that's true, it's important to know we also spend 9 out of 10 healthcare dollars in this province and in all provinces on treating conditions that could have been prevented. right? So we spend all of our money in healthcare at the end point of the system, after people have already gotten sick and after the treatments that are available are just helping by this much at the individual level. It doesn't mean we shouldn't do those things, but certainly there's in public health, we certainly think that there need to be more resources devoted to preventing, right? We get, if we only get $1 out of $10 out of healthcare dollars to prevent things, then we're destined to keep waiting for too long until things have already gone on for a long time, and until the things that you can do about them here are not as effective and much more costly than the things that you can do up here. So a good example that I have about that is when I was working in India on an elective with a public health physician in a rural community, right? And there are lots of different, beliefs about how babies should be born and what should be done when a baby is born and whatnot, right? But in some cases, in these villages, when a baby is born, you have to cut the umbilical cord, right? What do you cut the umbilical cord with? Well, if you're in a village, sometimes you cut it with whatever's around you, right? You cut it with, you could cut it with a rusty farm utensil, right? Which then creates a risk of tetanus and other infectious diseases, but primarily tetanus. So the problem is you have a lot of potential for infectious disease and a very, very, very simple solution up front, which is give people a clean and sterilized tool to cut the umbilical cord. Dramatically reduces the risk of infections after childbirth, right? Very, very simple, very, very effective, easy to use, easy to distribute, and very cheap. Compared to treating, now you have to treat kids if they have tetanus. So I'm not saying you shouldn't treat them, but certainly there should be more effort invested in making sure that all of the prevention tools are there, in addition to making sure that you have the treatment options for kiddos, right? So one of our projects that we worked on was actually working with women in the villages, but it wasn't just the women, it was also their mothers, because they have a tremendous impact on what happens when a baby is born, is the mother of a pregnant woman, and also the community, right? To help people understand what the risks are and then use very simple tools to reduce those risks. So that's the goal of what we're trying to do, is take maybe small interventions, but use them on a big scale at the population level to make a big difference. Next slide, please. So I'll just reiterate the point that in general, we spend too much money and time treating diseases rather than preventing them. We don't do enough on the prevention side. Next slide. So now to public health. What is public health, right? Public health system in Ontario is made up of public health agencies, public health researchers, and public health stakeholders. So I work at a public health agency. Lambton Public Health is mine, but there are 34 of them in the province. They're all funded by the province and also by local municipal governments. It's a cost-shared model, and they implement public health programs that the province has agreed to fund and implement, right? There are public health researchers who are not really formally part of the system, but the more we connect with them, the better we can learn what interventions work, how they work, how to apply them better or differently. And then we work with lots and lots of stakeholders. So all of the governments are stakeholders. All of the different sectors are stakeholders. So education and healthcare, industries, nonprofits, social services, community groups. It's really everybody, because public health is about everyone, right? So we work with everyone. One of the biggest connections that we've had, especially during the pandemic, is to schools, right? Schools are a place where lots of people come and go. There's lots of different things that are involved in keeping schools healthy. And we've had lots of consultation with them, almost weekly, actually, about infection prevention and control and things to do to with respect to COVID in schools, right? So there's so much work that public health does with a bunch of other stakeholders that is about keeping people healthy when they're in these different settings. Next slide. So we have 34 public health agencies in Ontario. They work across the province to implement provincial public health programs and services, and they each have a local board that governs that work. Every public health unit has a medical officer of health who is a medical doctor, but trained in public health. So some of them are also trained in family medicine, like I am, but most of them are trained fully in public health, at least, with maybe additional training. And we are responsible for those programs and services along with other administrative and professional teams, right? We have public health inspectors, we have public health nurses, epidemiologists, we have dietitians, we have dentists, health promoters, policy analysts, program planners. We have a whole bunch of different professionals that contribute to public health work. Next slide. And here are some examples of the things that we do. So we work with water operators to make sure that they have the right protocols to keep your water safe to drink. We work throughout the food chain to make sure that the good storage and cooking practices are followed, in addition to identifying any foodborne outbreaks and tracing them back to either get rid of the source or to notify people that a particular food source is contaminated and this is what they need to do about it. We do rabies prevention work. We do health inspections of restaurants and personal settings and other places. You may have seen some of those signs up on those places. When you go to a restaurant, there's a green sign that it's been inspected and whatnot. We do immunization services. That's become a big thing during the pandemic. Sexual health clinics, because a lot of people don't have access to that kind of care, depending on where you go across the province. We do children's dental screening programs, vision screening programs, hearing screening programs, home visiting programs for high-risk families and children. We work with schools on school nutrition. We work to promote physical activity. We work to get people to not start using substances, but if they do, to then work on getting them to use them less. We work on chronic disease prevention, right? Diabetes and hypertension prevention, getting people to do the things they need to do before they get to a place where they have disease. We work on healthy aging, which is huge, especially now through the pandemic, about how people are aging and the services that they need. Mental health, we do some work on. And then we have some work that we do on disease surveillance and reporting, coordinating on local health issues like opioids and substances or mental health and so forth. And then environmental health. So working with different government ministries and stakeholders to understand the health impacts of air pollution, water pollution, and ground contamination. Next slide. And medical officers of health, we've been around since 1882. Ontario was actually the first province to have a provincial chief medical officer of health, and then later had a bunch of local ones. So it's been around for, the role has been around for a long time. And the specialty training that's happened over the last 30, 40 years or so is in public health and preventive medicine. So it's a specialty of medical practice like cardiology or radiology or internal medicine, psychiatry, and so forth. And it takes 5 years of postgraduate training. So after you go through medical school, then another 5 years to basically learn about public health and preventive medicine. Next slide. So this is how I kind of parse this out a little bit, right? That if most medical doctors care for individuals, then they're dealing with this level here, the difference between what one person thinks about their health and what the doctor is seeing about their health and that conversation. So if we go to the next slide, and public health doctors work at the next level there. They work on how does the population see itself in terms of its health, and what are the objective measures at the level of the population, and connecting that conversation around what people feel they need to be healthy and what are the indicators that show about how healthy the population really is and what can be done about it, right? Next slide. So that brings us to this COVID pandemic, right? A pandemic is a worldwide or widespread disease that spreads quickly to many parts of the world. Previous pandemics have been caused by smallpox, polio, influenza, the plague, HIV, and now COVID-19 or SARS-CoV-2. And the way that pandemics generally end is that enough people have some kind of immunity, whether it's either naturally acquired immunity or natural immunity from having the disease, or acquired immunity from being vaccinated. It also helps when you have treatments that can reduce the disease burden, like we have with influenza, for example, and with some strains of influenza, and prevention measures where possible. So it's the combination of lots of people being immune, having some treatments that work on the disease, and continuing to use some prevention measures that helps you get out of a pandemic. Next slide. So COVID-19, just a brief summary of that, right? It's a coronavirus, which is part of a family of viruses, and they cause things like the common cold. But some of them cause severe acute respiratory syndrome, which is SARS, or Middle East respiratory syndrome, which is MERS, and now COVID-19, right? So it's important to remember that the virus comes from a family of viruses that also causes things like the common cold. But COVID, yeah.
Nice.
Oh, okay. But COVID-19 is a disease syndrome that's caused specifically by this virus, SARS-CoV-2, and the symptoms range from mild or even no symptoms to the potential for very severe disease that requires ICU admissions, oxygenation, and so forth, right? So next slide. Here are the key pieces that you need to know about COVID in case nobody has told you, but I'm sure that they have. Everyone is susceptible to exposure, right? This is some old data from the Public Health Agency of Canada and Health Canada that talks about where the cases are distributed across age groups, right? And so you'll see there are cases in all age groups. Over here, this is under 19 at the top and 80 plus at the bottom. And there are cases all through every age range. So everyone is susceptible to exposure. Let's move to the next slide. But age is the biggest risk factor for severe disease. So when you take that slide on Public Health Agency of Canada and you move to the fatal cases of disease, you see a very different picture than the picture that you had in the last slide, which is where everyone is exposed. But actually the cases of severe disease, 0.1%, 0.3% in this population down here, but 60% in the population of 80 pluses in terms of fatalities, right? So you see a dramatic shift in the risk as you get older and older and older from COVID, from having severe COVID disease. That's very, very important, right? Because although you might hear stories of a 35-year-old who's unvaccinated, who's in the ICU, the population level analysis shows that that is not a high risk category of people, right? And we always get a little bit torn by this because you don't want to be that person, but at the same time, in your population age group, if you're in this age group, your risk of having severe disease is very, very low, and we need to remember that as we go through the process of dealing with the pandemic. So the next slide, please. So here's what we know so far, right? We've had COVID come and go in waves. Each one has had slightly different characteristics in terms of who's affected and how quickly it's peaked, right? But we've had 2 years of experience with this now. And when you look at the general curve over 2 years, you can see it's starting to reach some kind of seasonality where we know it's going to be worse in the winter, just like other colds and coughs and flus. And we know it's going to be better in the summer when more people are outside rather than inside, right? We've had lots and lots of variants. So we've had Alpha, Delta, Gamma, now Omicron, and each variant has different characteristics. So Omicron is more transmissible. So in the same settings in which COVID transmits, Omicron will transmit faster and more easily, but showing in general that it's a less severe version in terms of the disease that it causes compared to some of the other variants, right? So that's very important. You're seeing across the world variations in how people approach COVID. Some countries say we want zero COVID, which is easier to do if you're an island, but still not 100% possible, but it's still easier. If you're an island, you can keep people out and you can do some greater isolation tactics than when places are more interconnected, right? There are COVID tolerant places that say, okay, well, we have to be able to accept some risk on this. And so we're gonna gauge and calibrate the risk to what we can manage in the healthcare system, for example. And then you have some places that are just purely COVID denying in their approach, like we're just gonna pretend it doesn't exist and not worry about it and carry on, right? And these are the different approaches that have been taken. I think the other piece that we have to remember is that even now, although much worse at the beginning, there was so much uncertainty, right? And it takes time for science to work. It takes time for people to generate the facts and evidence that they need in order to make decisions. But you're faced with the situation where you have to make decisions without enough of the facts, with a lot of uncertainty in the information that you're getting, right? So we're much more certain about COVID than we used to be, but in the early days of this, there was so much work to try to understand, what is this new thing? How does it spread? What kind of disease is it causing? And how severe is it? And so forth, right? Next slide. And so we've gone through 3 phases of this pandemic, right? The learning phase at the very beginning was probably 5-6 months of where did this come from? What's going on? What does it do? How does it spread? And so forth. There was a pre-vaccine phase, right? Where we said, we don't have a vaccine to stop this or to stop the impact of it. So what are we going to have to do? Well, social contact restrictions, masking and face covering, lots and lots of testing, limitations on travel, capacity restrictions, closing settings, getting people to work from home, and all of those things, right? And then there's a post-vaccine phase, which is we have a largely vaccinated population. The burden of the disease is very different from when most people were not vaccinated, right? We've dramatically reduced risk in all population groups, especially in those that are the highest risk, right? So if you think that before, let's say you were in the 80 plus population and your risk of severe disease was 63%, let's say, before vaccinations, we've taken that risk and dropped it down by 80 to 90%. So that's a huge difference in what the risk used to be compared to what the risk is now in that age group, right? Next slide. But we still have outstanding scientific questions, right? So there's still scientific questions around masks. How well do they work? Which ones work better than others? What's the purpose that we should be using them for and under what circumstances? What is the true impact of masking at the level of the population in terms of transmission? And are there some unintended consequences or harms? In the early days of masking, we heard a lot from people who actually had hearing difficulties and had needed, get by in their world by being able to read people's lips. And if you can't do that because everybody's face is covered with a mask, what impact does that have on your ability to just move through your life, right? Testing has a lot of scientific questions associated with it. What are the different types of testing? What are they good for? What are they not so good for? Like the rapid tests, a lot of people put a lot of faith into them because they sound like they would work really well. But rapid tests have different properties that make them more useful in some situations than in others, right? And so what are the benefits and harms of that? And then also lots of discussion around these capacity restrictions and closures, right? How well do they work to control disease? How much of disease do they control? What's the evidence of the impact, both positive and negative? Next slide. And then also lots of questions around the context, right? How long can we keep this stuff going when the longer and longer you restrict, there's all of these negative consequences, right? On businesses, on the economy, on children's learning and so forth. How long can you keep being socially isolated, right? The respiratory diseases are primarily spread through social interaction, but people are social. Like we know how much we miss being together and we know how important that is for everybody's well-being, right? So people can tolerate a limited social isolation for a few months, maybe longer, but certainly years and years and years of social isolation has impacts that we're only going to start seeing now as we start examining them critically, right? And then how are these decisions shaped around the popular kind of sentiment about what's happening with the pandemic? So next slide. And what have we learned? What have we learned about health and all of the things we know about health? How has that changed from this and other pandemics? Next slide. Here's what we've learned. One, health is global and local at the same time. So the things that are happening over there can actually have a big impact over here. And so it's really important to understand the decisions that other countries and other places are making and how they affect the course of the pandemic, right? Like we're very fortunate here because we've all gotten access to vaccines, right? There are so many countries around the world where even their 80-year-olds have not been able to be vaccinated yet because either the country does not have the vaccine or the country does not have a delivery mechanism that can enable that person to get the vaccine, right? And not having those two things means that you're at far greater risk in some of these other countries where there's been no vaccination than you are here. Also, not having those people vaccinated increases the likelihood that there's going to be more variants circulating, right? And so that's also a concern for the global effort to control the pandemic. Everything is connected. All of us are connected and we're all connected to all sorts of other things. And those connections actually drive and shape our health, right? So decisions that get made in one place impact decisions that get made in others. So all of a sudden, if you're saying over here, people get to use this kind of personal protective equipment, then the other sectors look at that and go, what about us? And what about us? And why shouldn't we? And so forth, right? All of the determinants matter. So your individual behavior matters, your individual knowledge matters, but even if you have the right behavior and the right knowledge, there are people who cannot avoid exposure to COVID because of the type of work that they do or the fact that they need to get care and so forth, right? And all of these things are mingled. So health is part of a larger conversation around science and politics and technology and globalization. And so it's fascinating, but also hard to untangle it sometimes. Next slide. So here's what we've been doing in public health during the pandemic. We've been doing disease surveillance and risk assessment. We collect and report on data about cases and outbreaks and try to figure out ways to share that data in a way that means something to people that they can use it for. We've been leading all sorts of different sectors in their responses to COVID. So we have tables that are for education. We have tables that are for private industry, tables that are for municipal governments and other government sectors. And we work with all of them to say, how are you managing COVID and what do you need? And what information can we give you to help you understand this and work on it. And then we try to evaluate what's working, what's not working, what level of impact is it having. Next. We've also been leading the vaccination efforts. So just in our area here, public health has been the lead agency on the vaccine rollout. So we've given out 250,000 doses of COVID vaccine since we started getting vaccines. We took them into long-term care homes. We've done mobile clinics. We've done mass immunization clinics that do thousands of immunizations a day. And that was public health leading it, but working with a bunch of different partners, right? A bunch of different groups came to the table to get it done. We've been leading pandemic preparedness efforts. So getting different groups ready for not just this pandemic, but the next one, right? And then we're going to start working to help people kind of recover through this, to say, what do you need to get back to the things you used to do? And what can you learn to do those things better, right? Like we've learned a lot about working from home. When I first started at the county in Lambton here in 2012, I said, oh, does anybody work from home? And they said, no, nobody. Everybody comes into the office. And, and now it's second nature to people to say, oh, sure, I can get this work done from home and it's no problem. And we've really shifted our thinking around it, right? So can we keep those things that worked out really well as we, recover from this? Next slide, please. Here's the opportunities and the challenges, right? So one opportunity is we've had lots of chances to be more closely connected to our friends in the healthcare sector, private sector workplaces, social services, so we can start sharing what we've been doing and how impactful it's been. All of you and the public are more aware of what public health does. And maybe that's going to result in some more funding that we can use to work on public health issues like mental health, substance use, building healthier communities. But there are challenges, right, in reinforcing what the expertise of public health is and how it's different. So, that's a hard one that's a hard conversation to have with some of my medical colleagues, right? Because sometimes, the training is actually very different based on what specialty you're in. And we know a lot about doing work in the community. And some of our hospital colleagues are more familiar with how work gets done in a hospital. And the things that they try to translate into the community don't always work when they come from a hospital perspective, which is why a lot of us say, we're experts at working with the community to achieve different goals, right? We work with different stakeholders who have lots of competing and conflicting interests. And sometimes that's hard to navigate through, like managing, what's a local need, what's a provincial priority, and how do we balance between them? Okay, next slide, please. Those are just some references. Next slide after that. Okay, so I hope that this has been a bit of an overview, right, about kind of what we've been doing, what medical officers do, what's going on with the pandemic and where we're going, and what public health is. It's kind of a lot to cover. It was sort of like some of these are actual courses that people will take for several weeks in public health programs. So I tried to condense it as much as I could. I hope it's been useful to you. I really appreciate the chance to talk to all of you. And thank you. Namaskar.
Okay, wonderful. It was so much loaded with so much of information.
Yeah, we can hear you.
Hi, Sudit. Sudit, you are my student.
Yeah, I know.
Now, teacher is thanking student. Number of participants commended you for this presentation. Most importantly, you did explain all the W's of your field. And that's really appreciated, right? Public health came into picture for a short time at the SARS time, right? And that time, Sheila Basrur was Toronto's health officer, and she did an excellent good job. But in between, it got lost. What's happening? But it's coming again to realize that this is a field which is very important in our life. And I really appreciate for helping, giving this presentation. As a customary, thank you on behalf of Forum. Now going back to the sidebar, which Mrs. Ghanekar just started, being a political junkie and 40 years spending in politics. I did try to win, I didn't win, but losing is not the end. I think you should run this time within a year or two. There will be election. And I want you to be the first Marathi MP going to Ottawa. If you do, and you become a minister, hire me as your aide. I'm ready to come. Right? Thank you very much.
Oh, thank you.
So
Thanks,
here's to
thank
you,
you.
Sudit.
Nice to see you all. It's really great to see you.
Sudit, big hug from here.
Thank you. Yeah, same.
Wonderful.
Okay. Very nice to see everyone.
It was nice seeing you.
Very nice seeing you, Sudit.
Bye.
Okay,
Sudit.
Bye.
Bye, everyone.
Thank you, Sudit.
Bye. See you
Thank
next
you.
month. Bye.
I will end the meeting and thank everybody. So our next meeting will be 20th of March. I will send an email first week of March.